Hi, everyone. My name is Michelle Topohunda. I am the Health Legislative Assistant for Congresswoman Nanette Badagan, who represents California's 44th Congressional District. She's a member of the Energy and Commerce Health Subcommittee here on the House side, and she's also chair of the Congressional Hispanic Caucus this Congress. Um, Really just want to thank everyone for taking the time for being here, from our hosts, Jewish Healthcare Foundation and Academy Health for holding this briefing, and for all the speakers for taking the time to join us today. Um, really excited to talk about my boss's bill, the National Patient Safety Board Act, um, which she has introduced with Congressman Burgess. So thank you to him and his staff, Jacqueline, for their leadership and partnership on this bill and in this area. My boss likes to say that addressing issues like patient safety are nonpartisan. So we're really excited that this is a bipartisan bill that she was able to reintroduce this Congress. Um, I think everyone deserves to have the safest and highest quality of care. And for the Congresswoman personally, she shared some of the challenges that she herself has faced when navigating the healthcare system, whether it be for herself or for her family members. And we also know that research has shown that marginalized patients, including people of color, disproportionately experience patient safety events. And this is a particular concern to the Congresswoman because our district is majority people of color. It's a very low income district, and we already experience disparities in health outcomes due to factors like the heavy pollution in our area. And so, this bill is just one step, we think, to addressing patient safety and improving care for patients throughout the healthcare system. So if you have any questions about the bill, please feel free to reach out to me. I'll leave my email in the chat, but um, really leaving it to the experts in the meeting to hopefully answer any questions that you have. With that, I'll pass it to Leah Binder, President and CEO of the Leapfrog Group.
Thank you, Michelle, and thank you for your personal leadership on this as well. We appreciate very much the work that you've done, as well certainly as Congressmember Bargan and Congressman Burgess. Both their leadership is really important to us. Leapfrog has been a strong supporter of the National Patient Safety Board movement, and I'm so pleased to see the leadership that we're now seeing on the Hill, thanks to you and your boss. So thank you so much. And I also want to thank Academy Health, my friends at Academy Health, for sponsoring this. And Erin Carroll, welcome to Academy Health. I know you're fairly new, so we're pleased to see you today. And then also certainly Karen Feinstein and the team at the Jewish Healthcare Foundation, based in Pittsburgh, but truly national in its incredible impact, particularly on patient safety, which Leapfrog has long worked with the Jewish Healthcare Foundation on many projects and is very pleased with their leadership on the National Patient Safety Board. So I'm going to start with a very brief overview of some of the issues around patient safety and why this should matter to absolutely everyone on the Hill right now. Every single one of us as a person has to worry about the state of patient safety in America. Let me share my slides. So it's very easy for a mistake to happen in a hospital. They're mistakes like all of us make. If I make a mistake, that means somebody might be late to a meeting. But if somebody makes a mistake in a hospital, a clinician, a nurse, sometimes that can result in truly catastrophe sometimes for the patient. You can miss a dose. You forgot about that lab report. A surgeon or can leave a sponge in after a surgery. That happens, sadly. A patient could fall. Those can be prevented, and they're often can even cause death in a patient. And it's very easy for that to happen. There's a lot of distractions in hospitals, things that, new patients come in or an alarm goes off for another patient, or things happen all the time in hospitals that are unexpected. That's the very nature of healthcare. But it creates an environment where mistakes can happen very easily and can be very harmful to patients. Because it's so easy to make these mistakes, sadly, there's some pretty awful statistics about it. I'm going to give you two. This is a statistic from the Office of the Inspector General. a report they did, I think, a year ago from the US when they did a report on the Department of Health and Human Services, and they found that 1 in 4 people admitted to a hospital suffers some form of unintended error or accident, so some form of harm. So those mistakes that I just showed you happen a lot. A 1 in 4 rate of harm is astronomical when compared to other industries. I think we'll hear more about today. And here's the other statistic I'll leave you with, and that is that here's a picture of Arlington, Virginia, which many of you may know, living in the DC area. It has a population of 230,000 people, and that is about the number of people estimated to die every year of preventable errors in American hospitals, just hospitals. It's not counting other settings where we have less information, but it is a catastrophic rate of harm. It would be considered the 3rd leading cause of death if we ranked it that way. So it is a very serious problem. It is, and it's sadly common, and it's something we can do something about. And here's the other part. There's lots of inequity, health inequity. It affects this as well. Leapfrog has worked with, my organization has worked with the Urban Institute and AARP and others to do some research on looking at literally millions of patient records thanks to the database at ARC. And we found that there's major disparities in who is more likely to suffer some of these harms. Black patients experience higher rates of hospital-acquired injuries or illnesses, usually preventable, than white patients, even in the same hospital, even with the same payer. So it isn't just that they're, say, at hospitals that aren't as good or something like that. There's lots of things that could be contributing to this, but bias is a major issue that is happening in hospitals, something we have to consider and have to consider as we try to address this problem. So my organization was founded to address patient safety. We were founded back in 2000. We were founded by employers. These are some logos of the original founders, but hundreds are involved. And they founded Leapfrog because they wanted to improve safety. There was a report that came out the year we were founded called To Err is Human, which is kind of famous. And it said that upwards of 100,000 people were dying every year of preventable errors in hospitals. I just showed you statistics. We know more now. And sadly, we know it's more than that. But regardless, at the time, that was a shocking statistic. And it was shocking to these employers who said, we want better care for our employees. And we think they should be able to really know how hospitals are doing before they make the decision to use them. And also that we can do better in how we pay for care so that we are paying for excellence when we see it. And I think there's been some progress in the past 10 years. I've given you some pretty dire statistics. They're sad statistics. There's not a lot of good news in patient safety, but there is a little bit. This was a major study that was done in 2022. It looked at the decade from 2010 to 2019, right before the pandemic. And it found actually serious declines over that decade in some hospital-acquired conditions, in almost every hospital-acquired condition they looked at. And you can see from this bar chart that these are, 25, 30% declines. They were looking at millions and millions of patient records. This is the largest study of its kind that's probably ever been done to look at that many records, and did again find these declines. Does that mean this is all good news? No, but it is a window of great hope because we hadn't seen any progress, zero progress prior to that. There had been a lot of discussion in 2010, after like the 10th anniversary of that IOM report I just mentioned, 100,000 people dying. And so there'd been a lot of reports then that nothing was happening or it was even getting worse. But now we're seeing a glimmer of hope. Some things are going in the right direction. We're doing some things right. So I like to think that Leapfrog is part of that, what's going right. We're part of it. There's lots of others, including some you're going to hear from today, who are part of that as well. But what we've done is we have issued letter grades for every general hospital in the country. You can see on the top of this slide is hospitalsafetygrade.org. You can look it up yourself. You can look up any hospital, any community, wherever you want. And it's based on data that's made public through CMS. So it is really reliant on that, as well as data we are able to collect thanks to employers getting involved and asking hospitals to please provide that information voluntarily. So anyway, we have letter grades on how safe they are. how well these hospitals do at preventing errors, accidents, and injuries and infections. And we do find lots of variation. Researchers have suggested that you have about 3 times a higher chance of dying in a hospital that gets a D or an F from Leapfrog than you do an A. But so it is worth looking at this. And there's also lots of information we make public, our US transparency, about how they're doing on these various indicators that we use, the 30 indicators of safety that we use. So anytime anyone has questions, feel free to let us know. We're happy to answer them. But today we're going to talk about modern solutions. I love that term because when you think modern solutions, I think for most of us, I think first thing is technology, right? This is going to be all about AI and all the technology that's out there, and there is lots of it, and it's really exciting. There are some real possibilities with technology, but technology is not something you just simply graft on to a dysfunctional system and expect it to just plug it in and it'll just work and fix everything. Now, for that, of course, we got to go back to those people working in those hospitals and how they function together, how leadership comes in, how culture comes in, how protocols are used, how we manage these systems, these complex systems, so that they are better able to protect the health and safety of their patients. And technology offers so many opportunities to turbocharge whatever these people can do, but the people have to be part of this equation. And I think we have 2 guests today to speak to this topic. They're going to help us to understand some approaches that are out there for both people and technology coming together with modern solutions to really accelerate our progress. We got to do much better on this. This is a solvable problem. These lives are savable, and we're going to need your help to do that. So I'm going to start with Paul Tang. He's adjunct professor at the Clinical Excellence Research Center at Stanford and practicing internist at the Palo Alto Medical Foundation. He's elected member of the National Academy of Medicine, which is actually, they produced that report that I just showed you, that original report in 2000, and has served on numerous study committees through the National Academy of Medicine, including a patient safety committee. He chaired that issued 2 reports. One, patient safety, a new standard of care, and key capabilities of an electronic health record system. So I'm so looking forward. Paul is really a leading authority on this, and I've followed your work very closely myself. I'm very much looking forward to hearing your remarks. So let's start with Paul.
Great. Thanks so much, Leah. So thank you all for taking the time on this really important topic. So we're so glad that you're interested, and we're so glad that you're sharing the time with us. You know, patient safety is not just a medical concern, it's really a societal imperative, as Leah was talking about. So in this brief talk, I want to talk about the opportunity we have, the imperative, and the policy implications. Congress really has an impressive track record, and we have one final ask for you to bring it on home. So I think we all realize that we're pretty darned expensive. And when you look at us compared to the other high-income countries, it's not, the message here is they're all bunched around this line, except for us. We're basically an outlier. And that's the piece that we gotta solve. So right now, we know we're expensive. That by itself isn't a problem. It does mean we have resources available. The bigger problem is we're not really getting a whole lot, getting as much as we deserve. So again, you look at those other countries and they're sort of hovering around the 10-country average. And once again, the US is an outlier. Sort of in short, we don't do so well. It's the maternal mortality, it's the longevity at birth, it's the infant mortality. We just don't do so well. Here's a big one. Avoidable mortality. What's that mean? It means we have the science, we have the know-how to prevent people from dying. And if you look at what's happened from 2009 to 2019, on the left, you have Switzerland. They have improved by 25%. Austria, 18%. Sweden, 21%. They're all double digits. Once again, we sort of stand out. We haven't even accomplished the double digits. That gives me, as a member of the healthcare profession, a lot of guilt. Why? We're leaving lives on the table. And there just really isn't a lot of excuse for that. What are the stats? Leah mentioned some of them. What's the so what? One, I'm going to talk about adverse events. In this case, I'm going to talk about the physical adverse events. There's emotional as well. But physical, unintended physical injury, not by the disease process, but by being affiliated, being cared for in American healthcare. And that's what we want to focus on. In our whole system, it's really voluntary reporting. In other words, you got to raise your hand and say, hey, I made a mistake or something bad happened. Because that's not a popular thing to do for adverse drug events, there's a 20-fold underreporting, and maybe more than that. What is the harm? Leah addressed this. If you or your loved one walk into a hospital or not walk into a hospital, 1 in 4 of those people are going to be harmed by an adverse event, a third of which are serious. So we're talking really serious information. Outpatients, 1 in 4 of us on this call have been to a doc. I'm one of those in the past month. 7% of us will have had an outpatient adverse event. The guilt, 1/4 of them are preventable. They're medical errors. We know better, we want better, and we can deliver better. And the remorse is simply, it doesn't have to be that way. That's the primary statement of this conversation is, we have the wherewithal to make it better. We just have to work together. What are some of these categories? Leah went over some of those. Medication errors, wrong dose, wrong indication, wrong person even. Diagnostic and treatment errors are something that have been really hidden because it's hard to elucidate. It means we either got the wrong diagnosis or we delayed the diagnosis and better things could have happened. There's a lot of things that we don't have great information about what's even happening today. A new one, AI. We're going into this. We need to go into this with our eyes open, and that is going to be one of the patient safety care categories of the moment, and that's included in what we're discussing. As I mentioned, it's the remorse that we can't get over because it just simply doesn't have to be this way. Why do I say that? Well, there are other industries that have safety as a big part of their business, and one of them is airline safety. It's sort of airline safety is sort of a foil for our patient safety for a number of reasons. One, we all do it. We all fly on planes. We all interact with healthcare. 2, we want to do it. At least we want to do it at least in the airline business. Not so much really on the care side, but we want to do this in the airline. 3, it's inherently a risky business. We're basically hurtling through the air, 35,000 feet, 550 miles per hour in a tin box. That's by nature a risky business. Because of that, we demand and expect safe operations from our airline and from our healthcare system. Well, what is the difference between them? One is because of the public demand, airline casualties have really plummeted, and that's why we can continue to fly. In contrast, we haven't made a huge dent in healthcare. Now, this graph is a little misleading. Originally in the IOM report in 1999, the estimate was about 100,000 lives maybe lost to medical errors. What's happening is we just have a little bit better idea of how many really. Not that it's increasing, but now we're at 250,000, and that's probably underreporting of deaths due to medical errors per year. So that's, as it's been said, jumbo jet going down every day, sorry. First thing I want to point out, it is not the people. My colleagues, the healthcare team, is by and large all mission driven and want to make this a better place, a more healthy country, just like the aviation team. So it's not the people that we're talking about. One of the key drivers is this data overload. The nice thing, and I'll talk about it a little bit, is that we do have it in computers, the data, but right now there's so much data coming at us. What we want is not so much data, but we want the insights so that we human beings can exercise judgment and make the proper recommendations. The other complication is there's so little time. Whether it's in the airline business and you're having a dangerous situation, or every single encounter we have in the inpatient or outpatient arena in healthcare, we're under limited time to absorb all that data and make better decisions. So no one said, as I said, aviation is not it's not unrisky by nature. And here's an example from over 25 years ago. And the two key points, one is obviously a mishap happened, and it's not just that they lost the baggage. So a mishap happened, but the more important point is there is an infrastructure in place, there's leadership in place, and there's authoritative investigator body in place with the resources to put this plane back together piece by piece. And the reason is the charge is to go figure out what happened, why did it happen, and how could we prevent this in the future? That's saying a lot, all those things. And a lot of that centers around, it's on the tip of everybody's tongue because it's on newspapers, the NTSB, the National Transportation Safety Board, is responsible for making this safety happen. And thanks to you, Congress, in 1967, you put together this charge for an NTSB as an independent organization within the Department of Transportation. Then in 1974, you even took it out of DOT and said, your reasoning was that an investigatory agency can't perform that objective function well unless it's totally separate from other agencies in the US, i.e., there's no regulatory authority. It conducts independent accident investigations for the purpose of making recommendations to improve transportation safety. It does such a good job at that because of its leadership, because of its resources, because of its charge, that 82% of the recommended actions are implemented. So the bottom line is we have this independent, authoritative, non-punitive, non-regulatory investigative team that goes and finds out why things go wrong so that we can prevent them in the future. Now, the last major US commercial crash was 15 years ago. So you sort of need data to keep making improvements. The other thing that came about is the ASRS, the Aviation Safety Reporting System, which was created in 1976 between FAA and NASA. It's run by NASA, again, because it has to be independent of a regulatory body. So it's a confidential system, it's voluntary, it's non-punitive, and it's independent. There's a real interesting thing I didn't learn until I was on one of these IOM committees. They have an incentive. So if you're a pilot and you're accidentally speeding faster than you should be, or you're at the wrong altitude, or you're connected to the wrong communication channel, as long as that was unintentional, it didn't result in an accident, you will not have a citation if you report that within 10 days. So there's an incentive to fess up in a timely way so that we can learn from it. And as a result, we get more and more reports every year. There's been 2 million of these reports, about 100,000 per year. That's really, really helpful. And you can report anything. Anybody down to the ground crew can report things. Oh, boy, that seemed unsafe, or I was speeding when I didn't mean to, or there's some other near miss. These are really important. They're way more prevalent than accidents, thank goodness, but they're really helpful in learning. And the output of learning is safety alerts, research studies, newsletters, or even actions as a result of what we learned from that. So the bottom line here is we have a confidential, incentivized, centralized, standardized reporting system so that we can learn to improve safety. How do we improve things? Well, this is an old cockpit, and the nice thing is it's transparent. Like, I know what's going on in all parts of this plane, and it's there right in front of me. The trouble is it's all data. It's this overflow of data, and I really need help in figuring out what's going on so that I can quickly react to an untoward situation. Well, what did they do? They took all that input and designed something, an artificial horizon. So it's taking all the data about the rudders and the flaps and figuring out how to present it to a human so the human can absorb it and make proper decisions. It has a backup camera so they don't run into people. It has a manual about this airport I'm in. In other words, it's translating that data into insights, as I was talking about before. All right, let's switch over to patient safety. As Leah alluded to, it wasn't such a great outcome. And in the follow-up quality CASM report 2001, they made the statement that not just that American healthcare is not currently producing, they said it's incapable of producing the kind of healthcare we want and deserve. And that we really needed to redesign the systems and have the information technology, which we did not have in 2001, to gather the information and help us make better decisions. That was the statement at that time. Okay, in healthcare, just like in the pilots, in ancient times, that's 10, 15 years ago, really, this is how we took care of patients. This is how we stored the data, and this is what we had to rely on. In just 15 years ago, only 4% of American docs had an electronic health record system. We use these things. 30% of the time, we didn't even have them. So we were asking for help too. And I'm really proud that Congress, now it was under duress in terms of the stimulus bill, but there's this high-tech provision in the ERA legislation that provided really a mere $30 billion over 10 years. And that incentivized American healthcare system to go from that 4% to over 98% really in just the past decade. 98% hospital, over 90% of the docs. This is truly enabling. So it's an enabling technology that came because of enabling legislation from Congress. Now, we've stuck all this information now in the confines of a computer, but this is sort of how we get the data back. And again, it's really data. It's almost like that old cockpit I showed you for the pilots. We really just computerized the paper record. Not enough insights. We're overburdened and burnt out, frankly, with the data that's coming in. We're really grateful to have the data, but there's too much of it that's not organized into insights, which is what we need. So as a follow-up to that, to the 1999 to Errors Human, we've had a number of IOM reports, one of which is this patient safety report that said, you know what, similar to the airline industry, we need a national patient safety database so that we could learn and improve patient safety. But you just can't collect data. It really has to be standardized. If it's not standardized with a common semantics, we can't combine it to analyze it, to learn from it. You answered that call again, Congress, in 2005 with the Patient Safety and Quality Improvement Act, PSQIA, which was really, really enabling. One, you gave us a place to put data, so providers could contribute data in a confidential, protected way. So that tries to relieve the fear of reporting into this environment, PSOs. One of the problems I'll talk about a little bit later is we have too many of them. The other thing was you asked Secretary of HHS to create this network of patient safety databases. Again, a common place to aggregate data because you can't learn from just one organization's data. You have to aggregate it over many, many organizations. So, well, what's happened since then? We have had actually a number of follow-up reports. By now, it's called the National Academy of Medicine. In 2012, the HIT Health Information Technology and Patient Safety Group. So we actually have we have errors that come out of EHRs as well, electronic health record systems. So we were looking at that and how do we improve the safety of those. But we concluded that, you know what, after looking at those 10 years, patient safety really hasn't improved measurably. And we recommended that Congress create this counterpart to the NTSB to be an NPSB, National Patient Safety Board. And I would add now, this board would also oversee the AI safety that we're so worried about right now. In 2019, the OIG also declared that the PSOs, you gave us the PSOs, that is, Congress gave us this concept, but we really haven't leveraged it enough. We haven't used it enough. And then indeed, we basically need this NPSB to help make those PSQIA tools effective. And finally, a few years ago, I chaired a committee that looked at the HRQ's report on patient safety. And unfortunately, we concluded also that the country is at a relative standstill and the trajectory just wasn't encouraging. And again, it's sort of, we have these tools, PSOs and NPSD, but we need this entity, National Patient Safety Board, to leverage them. You take a quick drink. So why the difference? Why are we still behind in patient safety when the airlines could make it safe? Well, there are some interesting insights. One is there's vested interest in the airline industry. An interesting part of that vested interest is the pilot goes down with the plane. Doesn't happen in healthcare. Another is the transparency. I talked to you about, first of all, it's very visible in a clustered event. These crashes makes all the headlines. Clearly, it's a business case for safety for the airline industry. The other piece, though, there's mandatory reporting. You have to report. Well, you have to. I mean, it's out there in plain view of everybody. But in a voluntary system, you have to go and raise your hand and say, you know what, either I made a mistake or something bad happened. Not a really comfortable thing to do. In a mandatory system where everybody has to do it, it's a lot easier to go, oh, I make mistakes too, which is not, you eliminate the first mover disadvantage. That's another lesson to learn. Data collection, I told you about these databases, they're standardized and there's one of them. That's a really great thing. And I told you about this important incentive for near miss reporting that we do not have in healthcare. In short, we have this NTSB that can take advantage of all these things that are above that bullet and put them to use in learning and making recommendations. Healthcare. Yeah, we do have a vested interest. I mean, you don't want to be embarrassed by doing something, making a mistake or having an adverse event. But it's not as if we go down with the plane. And there's this perverse disincentive. There's literally a higher reimbursement when bad things happen. That's a topic for a different discussion, but that's really different from the airline industry. Transparency-wise, it's really hidden. Yes, there's a jumbo jet going down every day, but they're hidden in all the nooks and crannies of our healthcare system. And I explained the problem of voluntary reporting instead of mandatory reporting. And we do have places to put data in theory, like PSOs, but there's like 108 of them right now, and they have different standards for collecting them. So there's no standardized way to collect the information. What little data we have in the patient safety database comes really from only 3 organizations. So it's, in other words, we haven't gotten it to the place that we'd want to have it, like in the airline industry. So the ask really is we need the same thing. We need this oversight board that is independent, non-regulatory, and can make sense of data collected and analyze it and make recommendations for future policy. So thank you. Thank you for putting on the table HR 7591, because you are authorizing the creation of this independent federal entity. You put it within the HHS that is non-regulatory. So it is modeled a lot over the NTSB, and that it would have investigatory authority to help us make recommendations for future policies. And it would also, you've asked it to create this patient safety reporting system that's the analog to the ASRS. And it would make recommendations and make the investigations public so that research organizations can learn from them as well. So in short, going back to the remorse, we have the capability to do better. I think we all would love to do that and would be thrilled to have that happen. Thank you for the PSQIA. It really did give us enabling legislation to create the protection and the databases. So that's wonderful. What we didn't count on, thank goodness, is we had this high tech that made EHRs possible. None of this stuff can be possible with paper records. So not only is this a mechanism to capture information, we could capture them in standardized way, in an efficient way, but it's also the effector arm of action. So once we learn what we should do better, we are going to do a lot of that policy implementation through EHRs, which we did not have on paper. The missing element is this NPSB. That would we would be able to take advantage of the legislation you've produced for us in the PSQIA and high tech and make it work to improve patient safety. So basically, to end on with hope, I think we have the elements to build this safety system in healthcare that would dramatically improve the safety. I think we are missing this NPSB part. And thank you for putting that on the table. We all would like to achieve a world where we close this patient safety chasm. So thank you. Thanks for being here, and happy to take questions at the end. Thanks.
Thank you, Paul. Thank you. That was an excellent overview. I have to add one thing to really thank Congress for, which is that although transparency in healthcare is not where it should be by any means, as you point out, it's a lot of voluntary reporting. It's not all voluntary reporting, thanks to CMS and really bipartisan effort on both sides in the past 10 to 20 years that has resulted in lots of mandatory data we didn't have before, like infection rates per hospital, for instance. So we're getting there, but that was an excellent overview. If you have questions, we're going to try to have time for them by the end of this. But if we don't, we will communicate with you directly and give you the answers later on after this. So please put your questions in the chat. And now we have Kristen Miller. She is the Senior Scientific Director of MedStar, Health National Center for Human Factors in Healthcare, and co-director of MedStar Center for Diagnostic Systems Safety. She's also an associate professor at Georgetown School of Medicine. So I'm really excited to hear from Kristen as well on how we're going to solve all this and what help we need.
Yeah, thank you, Leah. So I wanted to just continue the conversation and talk more about the challenge and also the opportunity. As researchers, we compel you with data and statistics, and you've heard some pretty powerful ones already today. But I wanted to start with a story. This is Alyssa. She's 9 years old. In 2007, she came home from a skiing trip. She was lethargic, had some swollen glands, a cold sore that wouldn't heal. Her mom thought that it might be mono, took her to the hospital, and she was admitted and diagnosed with leukemia. Initially, a resident physician incorrectly diagnosed her with anxiety, and this is important. She had a port installed to start chemotherapy, and she was discharged home. But the very next day, she was readmitted, and the oncologist said that she should have never been sent home in the first place. Her condition started to improve over the next couple of days. She was able to leave the hospital room, tour the hospital, watch a movie with her mom. But that night, she had complaints of stomach pain and discomfort. Her symptoms escalated, and the resident anchored on that initial diagnosis of anxiety and prescribed her anti-anxiety medication. Her mother raised concerns about the anxiety diagnosis, but her concerns were dismissed, and her condition worsened rapidly. Vomiting, inability to control her bowels, trouble breathing. She was put on oxygen, and labs were ordered. The results came back abnormal, but nothing was done. Her pulse was 174, and her blood pressure dropped to 81/41. While attempting to comfort their daughter, Alyssa's parents noticed that her legs were very cold, and they raised that concern to the clinicians. She was rushed to the ICU and then into surgery. She was brought back to her parents and were told that she wouldn't live, and they had to make the decision to let her go. Alyssa had a severe hospital-acquired infection known as C. diff, and this was a classic case of failure to rescue. The clinicians caring for Alyssa failed to spot critical lab values and respond appropriately and quickly enough. And it wasn't the cancer that killed her, it was all of these medical errors. In human factors, we often use this Swiss cheese model of causation. I think it's a fun visualization that helps us understand how a sequence of things can lead to pretty terrible outcomes. So think about each piece of cheese being a barrier, and then the holes within each piece of the cheese represent failures or where there were not protections in place. So looking at Alyssa's story, we can see we had providers in training. They weren't fully supervised. The hospital didn't have a pediatric early warning system. So like Paul talked about, there's so much data in the electronic health record, but we weren't able to have insights to know that Alyssa was at risk of deteriorating. The family was concerned, but there was no way for them to activate a rapid response team, which would have brought in new eyes and ears to Alyssa's care. There was some cognitive biases. We were anchored on the wrong diagnosis of anxiety. She was discharged home inappropriately without the correct medicine. She acquired, this hospital acquired infection. There were critical lab results that were missed and not acted upon. And then perhaps the most important piece was a failure to rescue. There was a delayed recognition of clinical deterioration. So all of this led to a missed sepsis diagnosis and ultimately the patient death. So again, we look at what went wrong, and there are a ton of things from a human factor systems engineering perspective. We look at the entire system. So we often see things like communication breakdowns, time pressure, staffing shortages. We also think about the cognitive component. So again, this anchoring bias or confirmation bias. Are we actually seeing what's going wrong with the patients? We might have incomplete or inaccurate patient information. There's gaps in what we're able to see and know based on previous admissions or if you were admitted to another hospital. We have limited time with patients. In a 15-minute primary care visit, we're trying to get an entire history or do a complete physical examination. And there's a lot of patient factors as well. So we think about things like language barriers. I think there's folks here representing aging community, and we see a ton of misdiagnosis in older adults as well. So we look at this from a human factors lens. This is a discipline that comes from industrial engineering, but also cognitive psychology. So we have the physical pieces, but also the cognitive pieces. And we look at the entire system, humans, their behavior, abilities, limitations. Errors are predictable and they're also preventable. So we're looking at the tools, the machines, the systems, the tasks, everything, the built environment to make sure that it's productive, safe, comfortable, and effective. And so much of what we do is focused on the user or the person at the center of this. Human factors has been applied in a lot of high reliability organizations. So you heard about aviation. This discipline has a long history in nuclear power, transportation. And again, thinking about both cognitive and physical aspects. We're looking at safety, but we're looking at other things as well. Are we being effective, efficient? We think about satisfaction and the problem with providers being burnt out in delivering care. We think about the learning curve. Are our brand new nurses up to speed as well as our expert nurses are? And are we ensuring operability and usability? So here's a few human factors at work to give you some examples of what we've done as a discipline. So think about something as complicated as medication. I think about my dad who's taking 14 different medications. How do we know if what we take in the morning versus what we take at night? How do we know what we need to take with food? Or what drugs might interact. And so something like a blister pack, where we've organized the medication together by day, by time, to make it simpler for people to not make mistakes. We can standardize processes and protocols. So we have things called crash carts in the hospital for someone who is experiencing respiratory failure. And we can standardize these so that no matter where you are in the hospital, you know which drawer has the medications, you know which drawer has the equipment that you need. Which would make, obviously, rescuing a patient a lot easier and more standardized. We try to enhance communication, and we think about this on the patient side. How do we help patients prepare for a primary care visit? What are the questions that they want to ask? What are the symptoms that they want to remember in that conversation? But also communication across clinicians. So something like SBAR, we standardize the way that we hand off patients. So we talk about the situation, the background, the assessment, and the recommendation in a standard way. And then lastly, I think building off of what Paul had talked about, there's a ton of information in the electronic health record, but that doesn't mean we're able to have clinical insights. And so a ton of health IT solutions, we can predict things like cardiovascular risk. We can predict things like sepsis if we have these smart systems in place that are organizing the data and making it meaningful. So really the opportunity, I think, if we try to benchmark what we're doing or we compare to other industries, something like 80 to 90% success could be seen as great. But I want to remind you that from a patient standpoint, that's unacceptable. And really reliability is all or none. In order to optimize patient safety, we need a framework that looks at reliability. Are we standardizing everything that we're doing? Are we ensuring that it's evidence-based? Are we learning from our mistakes as a healthcare system? I wanted to share this quote from one of our patient partners who was working with the hospital to say, we need to educate patients, right? We need to help empower patients. And they said, show me if that's going to save any lives. And she said, if it was your child, isn't one a number? And Eileen's son, unfortunately, died of a preventable adverse event as well. So the call to action, I think when we look at adverse events that are happening, we're doing it at a local level. And there's a huge opportunity for us to all learn from everything that's happening. This necessitates a team effort. We need the electronic health record vendors at the table. We need the clinical experts. We need the engineers and the psychologists, everybody to be reviewing the data to see how we can improve patient safety. We can standardize and uniformly look at data, and then really advanced analytics, applying AI to look at things in aggregate, informed by our expertise. The National Patient Safety Board would facilitate resource sharing and collaboration, but I think really importantly, the regulatory and policy support to make sure that we're pushing forward this evidence-based practice to enhance patient safety. And thank you for your time. Looking forward to the discussion.
Thank you, Kristen. That was excellent. It was also it's saddening. It's sad, I mean, to see the face of a child like that who unnecessarily suffered and died. That is hard for any of us as parents to look at, but that's what's at stake. That's the lives we're talking. That's what we're really talking about here today. So we are open to any questions or comments. We have a few minutes for them if anyone has a question or a comment. I see we have Rutam here. He is the CEO of Leah, which is a machine learning tool to predict and prevent maternal mortality. And we've talked a little bit earlier about maternal mortality. So I'm going to actually put you on the spot a little bit, Rutam. What do you think of all this?
Yeah, it's a pleasure. Thank you for having me. I have many thoughts, but particularly for the space of maternal mortality, I think one big issue with patient safety is that folks typically look at kind of the disastrous complications and don't look at the preventable ones. When people think about patient safety, you think about the surgeon that nicked the wrong artery or prescribed the wrong medication, but very little of the conversation ever is on the mom that had preeclampsia that shouldn't have, or the mom that lost her child that was completely preventable if they got social resources available to them. So I think the ability to have a committee that actually focuses on these kinds of patients and the actual true prevention, for which there are very little incentives in the existing system, would be a game changer.
So have you found that AI is going to help us to predict some of the, we've been hearing about AI as a it sounds like your company is looking at prediction of the signs that could lead to maternal mortality, but I've heard as well for other kinds of, errors and problems or issues that are preventable that could come up in the general spectrum of patient safety issues. Are you optimistic?
Oh, absolutely. Yeah. And I think if you look at the literature on this, whether you're looking at chronic complications or sepsis or even maternal morbidities, from about 60 to 80% of them are entirely preventable if you can at least catch them sooner. The issue just ends up being for innovators that there aren't really great incentives in the system to have proactive management. So a lot of innovators end up transitioning to something decision makers or hospital admin end up buying. But the potential for change is huge. Really, if you look at any kind of medical specialty, there are prediction models for every kind of outcome you can imagine. And there are models for determining what are the best medications or the next courses of action. But just the adoption piece and scaling piece ends up being the challenge for most innovators.
I think that gets to a point that Paul made earlier about how the healthcare industry is different in terms of the sort of business infrastructure that creates incentives for the behaviors we all want to see, and in contrast to aviation, which has a different business model and has many more incentives built into its DNA, so to speak. So, and I would add to that one of the key incentives is the economics of healthcare and how it's paid for and who's accountable for paying for what. that whole infrastructure is a huge part of the issue with healthcare. So let me ask Paul a question then, Paul. Do you think that given where we are right now, and given what the National Patient Safety Board could do, what is your outlook for 5 years from now? Do you think we're going to get there? Are we going to be able to really show massive improvement?
I think we could. I think let's pretend we had this NPSB. That ability to ask people to donate standardized data, and so that we can analyze not for punitive reasons, but for understanding what is happening now and what are the systems that lead to those errors. We can correct that. Because we have EHRs, it's both the source of the data, but it's also the instrument of improvement and interventions. So I'm quite optimistic that if we were to have this ability to investigate, to collect this data in a standardized way, and then disseminate the recommendations through these EHRs, really, we could do that. So that's what I mean. The remorse is we could do this. I think PSQIA was really enabling, and that we need this overarching independent investigatory body, the NPSB, to promote this basically. So we're almost there.
Okay.
That's the excitement. That's the opportunity.
Wow, that is great to hear. What about you, Kristen? I mean, I think you may have a different perspective on the prospects for EHRs. I think you would, it sounds to me based on your presentation, but also I know from MedStar and your background, you have a little bit of understanding of what it's going to take for the human system as well to be able to make best use of this technology.
Yeah, I think there's huge opportunities. And Paul, when you were talking about this idea of remorse, I think I feel similarly of like, we're setting people up to fail, and healthcare is really complex, and everyone shows up at work every day trying to do the right thing and trying to protect their patients, but the systems are just really complex, and healthcare in general is complex. So for example, there's roughly 200 signs and symptoms that we train clinicians on. There's over 10,000 diseases. So of course there's going to be diagnostic error that happens. I think health IT is probably the place where there's the most opportunity. We can get those unique insights. We can, apply AI and predictive models and just complement the clinical gestalt, the expertise that our clinicians have with this evidence base, right? Helping them make the right decision, to pick the right medication, to identify the right diagnosis. But again, this is, misdiagnosis, all of that, patient safety, it's a team sport. And I think we need everyone at the table together, bringing these solutions.
Well, and that is the advantage.
Yeah, I'll just build on what Kristen said and what she talked about. The implementation, the last mile, what she does, the human computer interaction, the last mile is so important. It doesn't matter what the science is. If it can't reach people in the ways they can absorb at the right time, it just won't do anything. So that's part of what she's saying. Everybody has to be at the table. It's informatics, not just the HIT and not just AI. And part of where we're coming up short with AI is we're not embedding all that knowledge, both of the workflow and the human aspects of it to make it effective. But we'll get there, I think. But I mean, Kristen's point is really important. We got to be thinking the last mile from the first mile.
And the first mile too, I would say. This technology has to be built on a foundation of what's important. And that's one of the issues I think with AI, which is we need to make sure that it is deployed to the benefit of the patient. And that is not going to happen automatically. We all have to have a role to play in making sure that that message is loud and clear for the delivery system. All right, well, I'm gonna have to bring this to a close for right now and thank both Kristen and Paul for your terrific presentations. This was real. I took lots of notes personally. I've learned a great deal from you, but I also share your enthusiasm for the incredible potential of the National Patient Safety Board and the work that is happening on the Hill around patient safety. We can really save a lot of lives together. So let's all get working at this. Now I'm going to turn it over to Erin Carroll, brand new to, well, sort of new to the to Academy Health. I'm going to preview our next webinar and talk a little bit about World Patient Safety Day.
Thank you for that. And I want to thank everyone who's participated in this call for their insightful comments and questions. Of course, a special thank you to the Jewish Healthcare Foundation for orchestrating the event, and to Congressman Burgess and Congresswoman Barragan for their leadership in sponsoring today's crucial conversation. Today, we delved into how technological innovations, enhanced communication strategies, and evidence-based practices are crucial in reducing errors and improving patient outcomes. And it's clear we face a significant challenge with preventable harm and deaths within our healthcare system. The good news is, though, we've identified a number of viable paths forward. Congress's support is vital, particularly through its backing of the Agency for Healthcare Research and Quality. Your collaborative efforts with researchers and patients are essential for disseminating and implementing the latest research equitably and effectively. I leave today's discussion energized and optimistic, and eager to continue collaborating with all of your offices on these initiatives. Looking ahead, as mentioned, I'm thrilled about our next briefing in this series, which leads up to World Patient Safety Day. This session is scheduled for September 18th from noon to 1 p.m. at a location we'll confirm soon. Please remember to RSVP in the chat. We'll make sure you're notified. The upcoming briefing will be moderated by former Congresswoman Allison Schwartz, featuring two of America's leading patient safety researchers, David Klassen from the University of Utah and David Bates from Harvard. They'll explore how a national patient safety research and development team could utilize new AI data systems and solutions to prevent injuries and harm. We'll also hear from Paul Tang. We'll discuss how this type of R&D team could take forward past recommendations to enhance our patient safety systems and policies. And additionally, Raj Ratwani from MedStar's National Center for Human Factors in Healthcare will present further innovative solutions. This second briefing will cap off the activities of World Patient Safety Day on September 17th, a day filled with congressional visits, March for Patient Safety, a remembrance ceremony, and more briefings. If any of your offices need assistance preparing for these patient interactions, our team's ready to provide the necessary research and resources to ensure these meetings are both impactful and effective. So once again, thank you all for your participation today, and thanks to our esteemed panel. And I look forward to seeing many of you next month and continuing our shared efforts to enhance patient safety. Have a good day.
Thank you, everyone.